Great. And starting the Crisis Jam, my name is Megan Haupt with the National Association of State Mental Health Program Directors. We are at episode 202. What a great number. And Dr. Brett Harris will be presenting on SBIRT Identify, which is Identify and Address Substance Use Among 988 Callers. Great. Really look forward to that. And just before that, we just want to go over that this is the website where you can register for the Crisis Jam. If you're on YouTube right now, this is where you would go. In the chat box is that link. It has past videos, past materials, all the tools we talk about, the quotes. You can get the weekly reminders for the newsletter. And as you can see here, there's last week's debate. We're going to be looking to do debates, more debates in the future. And that was on peers and high intensity care, be partners, or is it incongruent for peers? So very interesting conversation. All right, let's go to the next. And just a few highlights that were in the news. That calls to Oklahoma's 988 mental health lifeline, they decreased for the need for law enforcement involvement because of the excellent de-escalation that was done through 988. So just really excited about that. The link is in the chat box if you'd like to look further into that article. Congratulations, Oklahoma. And one of the things we know is that awareness for 988 has increased slowly. But it is growing. We are making progress, but we have a lot of work to do. So this article's awareness of 988 suicide prevention hotline number slowly grows, a survey says. So excited about the progress, but we still have work to do. I love these, the crisis trivia hot seat. So this is going to be with all of us. All right, let's see what we come up with, because this is a really cool hot seat. So mental health and cardiovascular wellness are increasingly recognized as deeply interconnected aspects of overall health. A study published in the Journal of the Heart Association has shed light on how treating mental health conditions can dramatically reduce medical emergencies for patients with heart disease. According to the Journal of the Heart Association study, what was the risk reduction for emergency department visits when patients with heart failure or coronary disease received both psychotherapy and medication for depression or anxiety? So what a great finding in the first place, but go ahead and put your guess in the poll, not the chat. Go ahead and do one of these. And let's see, as an audience, as a community, what kind of knowledge we might have or guesses we make. And we'll give just a little more time just for people to submit their answers, because don't they all look right? But anyway, there is one right piece with both psychotherapy and medication. All right, are we ready to reveal? Wow, totally split. All right. Well, we're all smart then. Okay, so let's see what we come up with. All right, let's reveal the answer. Woo! 74% reduction. When I learned this, I was flabbergasted. What a significant number. So this finding underscores the incredible impact of comprehensive mental health treatment. This research highlights the link between mental and cardiovascular health and also provides compelling evidence for a holistic approach to patient care. Great work, Crisis Jammers, because it's a tough one. Who would think it would be that high? But that speaks to that comprehensive care. And also want to thank Stephanie Hepburn for bringing attention to this article. Very important. And So here's the article, the impact of mental health treatment on outcomes in patients with heart failure and ischemic heart disease. Now, I learned ischemic, and if you're a doctor, you know what ischemic is, but I asked, and it's when the tissue dies from a heart attack. So the outcomes are more positive if somebody's getting mental health treatment. All right. Okay, really excited to introduce Dr. Brett Harris, who's going to do a presentation on screening, brief intervention, and referral to treatment. And Dr. Harris is with the University of Chicago and is a senior research scientist at NORC at University of Chicago. Go ahead, Dr. Harris. Just thrilled to have you on.
Thank you so much, Megan, and I appreciate your energy. I think that's a great way to get started. I want to thank you for inviting us to present today, and I also wanted to second what you said about the 988 counselors and just want to express my gratitude for all of the work that they do in helping those of us who are struggling. And the purpose of this presentation is really to focus on substance use and just think about the impact that our counselors can have, the improved impact by just kind of implementing an evidence-based substance use prevention, early intervention practice. And I will mention, so screening, brief intervention, and referral to treatment, what I'll be talking about much more in depth over the next 15 minutes, is what we call SBIRT. So when you hear me saying SBIRT, that's what it is. So at NORC, we have an SBIRT suicide care model we call SBIRT SC, which essentially integrates suicide care, those elements of screening, intervention, so forth, into the SBIRT model. And we can tell you that what we're going to present today in SBIRT does integrate very well into the work of the call centers that they're currently doing. So that's kind of that's like the biggest question we always have. And yes, it does integrate very well. So I'll get started just to emphasize the connection between substance use and suicide. So those who are thinking about suicide are more likely to be struggling with substance use. You can see, just by the slide, I don't have to go over them, but like suicide rate for those with opioid use disorder, 6 times the general population, regular opioid users, 14 times more likely to die by suicide, and so forth. And of course, alcohol does increase risk, and for example, more depressed mood, and less ability to be able to cope or really look at those coping strategies. So with that being said, many 988 callers and texters will be struggling with substance use. So think about it in a few different ways here. So since the launch, and this is not up to like today's date, but pretty recently, 988 received nearly 10.8 million contacts. And then just like I was saying on the last slide, there is quite a connection between substance use, mental health, and suicide. And last, I wanted to point out that there's wider promotion of 988 for substance use and emotional support. So you can see the image on the right comes from the SAMHSA toolkit. You can see there, 988 offers 24/7 judgment-free support for mental health, substance use, and more. So you can see that fairly recently, SAMHSA shifted a bit in the promotion of 988 from being around crisis or suicidal crisis to being more about emotional support and can be used for other things like general mental health, depression, anxiety, substance use, and so forth, which is really great because this is a resource that should be used more widely. The shift from the National Suicide and Crisis, the National Suicide Prevention Lifeline to 988 and what we now, a lot of us call the 988 Lifeline, I think it just does a great job in and of itself to get more people to be using 988 for more an upstream public health approach. So what I'm saying here is that the more calls to 988 and then wider promotion for substance use will bring in more people either calling for substance use or calling about mental health crisis or suicidal ideation, but are also struggling with substance use. So I also want to emphasize here, so this comes from Kaiser's report, which I have linked at the bottom there. The volume of 988 contacts continues to increase. So you could see each year, this is the data from May, significant increases. So that just means that there'll be more and more calls as people learn about 988. So we were just hearing that it's slowly increasing the recognition and use. So we think it'll just continue to increase with this promotion and also the wider promotion of it. So with more calls and texts, that just means more people calling and texting with substance use issues. So what does this mean? So being prepared to identify and address substance use will result in the best outcomes for callers and texters. So there's a few different things here at play. Those struggling with mental health and thoughts of suicide may be using substances to cope. And they just might be calling with looking for help with their substance use based on the broader advertising that's happened. And as I was pulling these slides together, I was looking for a slide an image that had the substance use promotion, and I found several states as well that were really promoting in that broader public health promotion versus the more narrow crisis and kind of suicidal crisis messaging that had been used before. I think this is really important because, and I will mention that we did a study, focus group study, looking at the advertisement around kind of using the term crisis and suicide, and people that were struggling with their mental health and should be using 988 weren't, because they said that they felt that the services were not meant for them, that their crisis didn't amount, what they're struggling with didn't amount to a crisis, and they didn't want to take resources from other people who needed it more. So I think this is just more and more going to bring in more people, and then people calling for substance use. So that means that counselors will need benefit from training and evidence-based practices to identify and support those struggling with substance use. So the thing is right now that counselors probably are identifying substance use, and maybe not everyone, but they're identifying it and doing something to address it. There really is no across the board protocol for doing this. And I know that there are some kind of outlines of information that can be provided. And I know Vibrant does have an optional set of information that counselors can use and I guess take an optional training in this. But it's SBIRT, which I'm going to talk about in the next slide, is an evidence-based practice that can be used, and I think used very well and integrated into the suicide prevention protocol. All right, so SBIRT can be used for alcohol and other substance use. So it stands, I'm going to say it again, stands for screening, brief intervention, and referral to treatment and follow-up. So what is SBIRT? It's been, and I'm going to say this a couple of times because I think it's important. It's been endorsed and funded by SAMHSA for many years. I think it started in 2003. And I've been a part of several grants focusing on SBIRT funded by SAMHSA. So we definitely think that this is important for call centers. It's a universal screening using, there's a few different ones that are recommended. For example, the audit for alcohol, the DAS for substance use. There are specific ones for adolescents like the CRAFT and also the S2BI. These are very short screeners. It's just a set of questions. And when these questions, and a lot of them have these pre-screens too, so it's like even shorter if someone is screening negative. So in that case, it doesn't take much time at all. So what happens is it's a set of usually 6 to 10 questions, and go through those questions. And once that's complete, the counselor will know essentially what to do, what level of intervention to perform, and it can be anything from brief advice to a referral to substance use disorder treatment or for assessment of that potential substance use disorder. So the good thing about these screenings, they're all validated and standardized, and they've been really supported for the use for SBIRT. One of the things that happens immediately when someone screens positive is to provide a brief intervention. So that conversation is really looking at that person's substance use, how it really kind of goes with their day-to-day lives, looking at the pros and cons of use, and using motivational interviewing to really look at how someone can reduce their use, or even kind of stop using, depending on what the situation is. And for people who are kind of using at a higher level, it gives the counselor the opportunity to encourage that person to go and essentially connect to that referral. And that referral is specialized substance use disorder treatment. And it could be actually used for other services that might be helpful as well, like, self-help groups and so forth. But the basic idea behind SBIRT is that services can and should be provided for substance use outside of a substance use disorder treatment setting. So it is what we would call a public health approach that occurs in so many different settings outside of that. And for the very few people who need a connection to substance use disorder treatment, that they can make that. But what I like to kind of think about is a pyramid, and you have like the very top of that pyramid is the people who have a substance use disorder, and then that bottom is the people who have, like no use or, kind of minimal use. And then that middle of the pyramid are those people who might be engaging in risky or harmful use and essentially wouldn't be identified or get any kind of intervention if we didn't implement something like SBIRT. So what I'm going to emphasize one more time is that SBIRT is easily integrated into what the call centers are already doing around suicide risk screening, assessment, and management. Hence like our experience on that SBIRT suicide care model. So one of the #1 questions, besides can this be integrated with what we're already doing, is there evidence behind this? So we have so many training decks on SBIRT suicide care, and I know that we have tables like this. So I went through, and I think there were like 6 or 8 slides like this. So I just picked one for the visual, essentially, to show you that yes, there's a lot of evidence, and it goes back over 20 years. This slide's all about analyses, basically just showing that that SBIRT is able to reduce alcohol and other substance use. It leads to positive social outcomes, and the real goal is to not just reduce use, but to prevent negative outcomes. Some of those being like substance use disorder or driving under the influence. Injuries, a big issue related to substance use. So I'm not going to get into all of the evidence here, but there is a lot of it. And SBIRT is widely supported. So I mentioned SAMHSA, so I will say again, SAMHSA funds SBIRT grantees, and they've been doing that since 2003. Also have NIH, the World Health Organization, Public Health Service, the American Academy of Pediatrics. And something else is the U.S. Preventive Services Task Force. So I know that a lot of organizations in healthcare look to this to essentially endorse or recommend services. And once those services are recommended, they're more likely to adopt and implement them. So SBIRT, screening and brief intervention, services are recommended by the U.S. Preventive Services Task Force. So we highly encourage the implementation of SBIRT in call centers. SBIRT is a very adaptable intervention. So you can see it's been implemented in all these different settings, very unique, different types of settings. And I will say that I'm like looking at this right now to see if it's all on here, but I see the after school program and community centers. We even have a program going on right now where we have outreach workers going into these community settings to implement SBIRT. So you can see it's like very adaptable. So in that one, we actually have had people go into barber shops to do screening and brief intervention. And we've also had people go out to like community health fairs, out in like outside, at the different tables and do this work as well. So definitely this can be integrated into call centers, and that just the whole kind of, mechanism, the model is adaptable to meet the needs of the setting and the, like the protocol that's being used in that setting. So where to start? So I didn't get like into detail about SBIRT and what it is, but we have lots of training out there, ranges from like, 2 or 4 hours to like 2 days, depending on, with like role play and so forth. But we do have a lot of free resources available on our website. So you see our website there, it's www.sbirteducation.com. But I'm going to highlight a few different things here. So we have our SBIRT Learner's Guide. So this one here that I have the picture for is specifically adolescent SBIRT, and you can just order that on our website. I have the hard copy, and I can tell you it's like 300 pages. It's very comprehensive, and people can really learn SBIRT through that. So you can get really comfortable and confident in delivering SBIRT. We have a training manual and we have a training deck with speaker notes. So those are available for anyone who wants to deliver this training. And then we also have plenty of on-demand learning. So we definitely suggest you checking out our website to get some free resources. We also have a section on our website on our SBIRT suicide care model. So that's, again, the model that integrates suicide care into SBIRT. We wanted to focus this presentation specifically on SBIRT because we know that the call centers do kind of implement very similar things to what we have in our SBIRT suicide care model with respect to suicide prevention. So without further ado, I want to jump into our discussants and our roundtable discussion.
Great. Thank you so much, Dr. Harris. What a fantastic presentation. And with only 15 minutes, it's like you covered so much ground. So really appreciate you and your work. I'd like to introduce Tracy McPherson. Dr. McPherson is Principal Research Scientist, NORC at the University of Chicago. Dr. McPherson, are you on? Can you hear us? Okay. I know you're in your car, so you may have lost connectivity, but let's go to Dr. Sterling, who is Senior Scientist, Kaiser Permanente Division of Research and co-director of the Center for Addiction and Mental Health Research. Dr. Sterling, what are your thoughts, comments, or additions?
Well, I can tell you that we have a really successful program of SBIRT in our health system. So we, starting about 10 years ago, leadership decided to implement SBIRT, and we have, in the past 10 years, conducted over 20 million screenings and about 1.3 million brief interventions. And that is, and so it's been integrated into the rooming process. So as patients come in, medical assistants just ask about alcohol and drugs, and then physicians, if somebody is identified as screening positive and, using at an unhealthy level, then physicians provide brief interventions. All of that is to say we have done trainings, and I think I want to underscore what Brett was talking about in terms of SBIRT's flexibility. So it is very flexible in terms of its length and format. It can be a brief intervention of just, 30 seconds to a minute, or it can be, last several sessions. And in that way, it can fit into a number of different sort of contexts. Also flexible in terms of the person delivering brief interventions. So we've trained doctors and nurses, behavioral health clinicians, medical assistants, health educators. I know that peers have been have successfully delivered the brief interventions. And so it's an incredibly flexible and evidence-based intervention. It's also, as Brett said, it's very effective, and it's effective not just for reducing substance use, but it's also been shown to reduce mental health symptoms and depression. We found that in the patients that we serve in our health system. So it's a very powerful tool for clinicians to use. I think it's really consistent with, everybody's orientation probably who's listening to this. So it's very person-focused, it's non-judgmental but directive. It's informed by motivational interviewing, which I think that everybody's familiar with, and it really explores people's relationship with substances and that how they affect mood and physical health and spiritual health. So I think what I would say is the key a key to its success is overcoming stigma, and not just stigma among patients or clients, but also stigma that clinicians might feel. It talking about alcohol and drugs kind of remains an awkward conversation, and one of the things that we have really tried to do is normalize the discussions about alcohol and drug use so that they are just as it becomes just as normal about as talking about other health conditions, about talking about food or sleep or depression symptoms, so that so that it doesn't become this barrier to talk, introducing the subject. Excuse me. And I think a key to that is using the sort of evidence-based screening instruments that Brett was talking about. Excuse me, I'm going to stop. I apologize.
No problem, Dr. Sterling. Please take care of yourself. And that's what we always want to do, right? Is take care of ourselves. So let's go to Dr. McPherson. Dr. McPherson, what are your thoughts and comments and any additions and any piggybacking on what Dr. Sterling may have said as well?
Yes, thank you. Yes, and thanks for sharing that, Dr. Sterling, and Brett, for what you covered and talking about the real opportunity that I think we have in this space. It's really great to hear about the shift in emphasis as someone who has devoted most of their career to SBIRT, near and dear to me, to see that and hear that shift around emotional support and substance use. I have thought for a long time that call centers and other texting services are very promising yet underutilized for delivering SBIRT. In fact, I think you shared, Brett, a lot of the settings, and I've done work in almost all of those, and we've developed curriculum that can be used in almost all of those. One of that you mentioned, but I think one thing that folks don't know much about, and probably federal agencies, health systems don't realize that some of the call center work has been done. It does not get a lot of attention or promotion. It's not always published because some of it is proprietary. But fortunately, I have had the opportunity to work with employee assistance programs and managed behavioral health care companies who use call centers. At the time, texting really wasn't the thing, but a clinical first model where they have direct access when they're calling in to a clinical provider, and other types of staffing. So some aren't a clinical first model and they have access to staff who may not have a clinical social work or clinical counseling degree, which is often what we would find in call centers. And we did feasibility studies and found that it was quite feasible to implement in call centers. And so really about, implementing and adapting into the workflow, into the existing workflow without disrupting, creating major disruptions to how the operations, what are the operations in that call center, but it is feasible. And in fact, we did find that one of the interesting findings was that often the primary presenting concern wasn't substance use. It was an emotional concern, usually depression, anxiety, and even the secondary concern wasn't substance use. But when we looked pre and post at rates of identification, we did find that indeed when you implement a validated brief tool into your existing workflow, your screening workflow, that you can identify individuals who may have a substance use concern, who are at risk, and that may be also exacerbating the primary presenting problem that they actually reached out originally to get help. So it was really interesting observation, and I think it surprised call center staff that folks are having substance use concerns, and that they were able to identify them, and that people were willing to talk to them about them and answer those questions. They really thought they might not, and they did. So we did a lot of debunking of myths around people will talk to you. So yeah, those are some of the really interesting things that I think we've learned from our call center work.
Great. Thank you so much, Dr. McPherson and Dr. Sterling, and Dr. Harris. And I have questions. One was in the chat box about, is the training in Spanish? Whoever could answer that. Is there a Spanish training?
Yeah, I can take that. Megan, this is Tracy. Yes, actually, we do have trainers who are multilingual. There aren't very many of them out there, and we would love to have more people trained. But we did adapt some of the curriculum, and the screening tools have already been translated. It's typically brief intervention protocols that haven't, mostly in Spanish, yes, less so in other languages. But we do need more. We need more folks who are trained.
Okay, great. And also, how much time is the training for call takers or call counselors? What would that entail?
Yeah, I'm always a proponent of designing and customizing the tailoring of the curriculum or the training to the individual. So you really have to understand what the model is and what the roles are. And if there's an individual who is answering the phone, but they're not doing the screening, we really need to make sure that the training pertains exactly to their role, but they have a general understanding of everybody else's role. And that kind of training is rather, is much shorter in duration. When you move to thinking about other professionals delivering clinical type services or, doing a screening and brief intervention, but not considered a clinical service, because there are lots of folks who do SBIRT that are not clinicians, the training does vary. And it does vary depending on how many screening tools, how much, the duration of the intervention. So as, Dr. Sterling was mentioned, there are call centers who really were looking for a 1 to 3 minute intervention. Every minute has an impact on the delivery of services. Others were looking for a 3 to 5, 5 to 7, and you really need to tailor the content and the duration of that training to exactly what those folks need. And again, making sure they're aware what everybody else is doing. So it can be a rather short in duration training within 1 to 2 hours, and it can be longer. It depends on kind of the depth and breadth of what you're hoping to implement.
Great. Thank you. And just wondering, is there such a training, an SBIRT training for family members that could, that's relatable in a family way?
Yeah, that's a great question. It's not typically been a model that has often included family members, except for in the case with young people, adolescents and transitional age youth. And there are evidence-based models out there, including Teen Intervene, which has been highly supported by various organizations. And it does have a family component, caregiver, parent, other caring member. Dr. Sterling may also know of some other models, but that certainly is one. And I will mention that in some of our other adult SBIRT work, even when it wasn't formally part of the model, there are excellent resources that, from SAMHSA and other organizations about how to integrate the family into the conversation. And if they're willing, if the individual is willing to have that family member, brought in, there are ways to do that. And we can draw on a lot of the information that SAMHSA and other organizations have to inform how we're going to do that.
I would also add that the Partnership to End Addiction has a number of really great resources around family involvement. It's very much focused on adolescents and young adults, but they have a number of tools, risk assessment tools, and so forth. So.
Great. And there's one participant that has a question that their understanding is that SBIRT is required in terms of training. So they weren't sure kind of, I guess, how it's being proposed to be integrated, if it has to already be integrated, but I didn't know what that piece. Is it required? Is SBIRT training required for call takers?
I
Yes,
might be able,
and
sorry.
go ahead, Brett.
I was gonna say I might be able to jump in with this one because we did talk with Vibrant ahead of this, and this is how we got invited to this presentation, is that there's an outline of some content for around substance use specifically for call takers, and it's optional. So they were looking for something potentially that could be good for call centers to learn about an evidence-based practice. And this one was one they thought, would be of interest. So that's why we're here presenting. And I think that what it might be is that some of these elements might be being delivered by the counselors. So like, for example, they might be asking about substance use. They might have some conversation around it. But the thing is, when we usually approach organizations about SBIRT, sometimes they're like, well, we're already doing this. But when you have a deeper conversation with them, they're not really actually doing it according to the model, because these different elements within it are evidence-based and they have a certain protocol along with them. So it's more than just having a conversation or asking about substance use. There's actually algorithms behind these, and there's research behind it. So I think that might be also, some of the confusion involved in that. But to my knowledge and to what the discussion we have with Vibrant, that this is not required of call centers.
Thank you so much for that clarification. That was a really important distinction. And so just want to thank you so much for presenting, Dr. Harris, and thank you for your comments, Dr. McPherson and Dr. Sterling. Just very informative. Thank you so much for being here today. Great. We're now going to move to the next element with the SAMHSA update with Tiffany Russell. Go ahead and take it away, Tiffany.
Thank you. Hi, everyone. I'm Tiffany Russell. I am the Chief of Crisis and Justice Initiatives with SAMHSA's 988 team, and so happy to be here to provide you with the SAMHSA update for today. This is the season of giving, and SAMHSA wants to get in on that. And so we have several great resources that are on their way to you within the next 2 weeks. First, before I start talking about those publications, I do want to thank everyone that has participated and given feedback on the publications and provided public comment on our documents that we have coming out. As you know, we are working on the national update for our guidelines for crisis care, which should be available very, very soon. And we also put out a document on crisis definitions, and you also provided feedback for that document. And so we are now working behind the scenes to integrate those wonderful comments and all of that feedback into the finished document, and they'll be available very, very soon. But also, I want to share that tomorrow we are releasing a practical guide. It is titled Advising People on 988 versus 911, a practical guide for healthcare providers. And we are really excited about this document going live tomorrow. There has always been a lot of confusion about when should you use 988 versus when you should use 911. And we wanted to provide something that could easily explain that, the difference between the two services. But we also wanted to provide it for a very specific population. And this particular document is for primary care, behavioral health providers, as well as EMS providers. We are hoping that these individuals will be able to catch people either coming into crisis as they're going into a crisis, or if they are coming out of a crisis. And so that they can help them to kind of guide them about what options they have available while they're in the midst of having a behavioral health provider, not only for them, but also for their friends, their family, their support system, to also have that information. And so we really wanted to encourage and support primary care, the behavioral health provider, and the emergency medical services with the information they need to integrate crisis care into their routine practice. And we are hoping that with this information that providers can assess their patients more holistically and educate them and their trusted networks about the available crisis care options. And so this document, as I mentioned, is going live tomorrow. It will be all over our social media. We will be sending it out to all of our listservs, and it will be available on our site tomorrow. So we're really excited for you guys to have that. And that's all for me today.
Thank you so much, Tiffany. That's great news. We look forward to it. So let's move to the NASHBID update. We have Dr. Jessica Pollard, who is the Senior Behavioral Health Advisor at NASHBID. Dr. Pollard.
Great, thanks for having me. So I wanted to use our last NASHBID update of the year to touch on just a few highlights from 2024 and looking ahead to 2025. And, NASHBID's mission is really about improving access to and quality of mental health and co-occurring services, which would really not be possible without the support of SAMHSA, the states and territories, and our many outstanding partners. So some of the ways that we work to make those improvements is really through technical assistance, resources, direct support, consultation. And 2024 saw the launch of a few new technical assistance centers that ultimately support the expansion and improvement of crisis services. So we have SPARK, the SAMHSA program to advance recovery knowledge, the Administration for Community Living's Link Center, which bridges IDD and mental health systems, the SAMHSA's Early Serious Mental Illness Training and Technical Assistance Center, which we know early intervention will reduce need for crisis services, but also we're developing resources through that around the intersection of crisis and early intervention, the SAMHSA CCBHC State TA Center, and of course, major crisis components there. And these TA centers are in partnership with National Council, WESTAT, C4 Innovations, National Association of State Directors of Developmental Disability Services, National Association for Dually Diagnosed, and National Association of State Head Injury Administrators, and so many more. So just wonderful collaborations to make sure we continue to improve services. Also in 2024, SAMHSA funded and NASHBID administers the Transformation Transfer Initiative, or TTI awards. So there are 48 awards that we announced recently, $250,000 each to states and territories supporting implementing and expanding crisis services. So the categories this year are community-based services for justice-involved individuals with SMI or SED, community crisis service mapping, so we can make sure we have that coordinated crisis care and suicide prevention for underserved youth, workforce wellness for the crisis workforce. How do we build resilience and prevent burnout? Training and professional development of the non-clinical workforce, treatments and support for high acuity children and those with complex needs for out-of-home placements, or at risk rather, for out-of-home placements. And I'm going to put after this a link in the chat for the state summary so you can see all those amazing products. And we're really looking ahead to 2025, continuing the mission, which we see as a bipartisan mission. So we're really optimistic about a number of things for the coming year. We are launching yet another and really important training and technical assistance center, the Serious Mental Illness TTA Center, in collaboration with National Council, APA, Psychiatric APA, C4 Innovations, and Bizzle Group. And our very own Carrie Slatton Hodges, another senior behavioral health advisor here. We're pleased to say, though we're sad she's leaving our team to some extent, is taking over as executive director of NASHBID's Research Institute, our sister organization. So that'll be an outstanding collaboration. And NASHBID will be joined by a few more staff in 2025 who will round out our team and highlight the important priorities that we have. So around child focus, continuing work in crisis, early intervention, system transformation, sustainability, maternal mental health. And so we're very pleased to announce that we'll be joined by Kirsten Burrow, Ronio as a senior advisor for health policy. She has over 20 years of experience. Most recently, you're likely familiar with her work at CMS as a senior policy advisor in the Office of the Director. David T. Jones will also be a senior behavioral health advisor at NASHBID. He was most recently the chief behavioral health officer for the state of Illinois, leading their behavioral health transformation. Louise K. Johnson, a senior behavioral health advisor focused on children's services, and she has 3 decades of experience in children's mental health. Recently, a director of the Division of Children, Adolescents, and Families for South Carolina's Department of Mental Health. And so, Megan, this is our gorgeous NASHBID team, as you know. And we joke a lot about acronyms, and particularly our own. But I want to say that I think it's festive. It's a festive acronym. Do you know why?
Why?
Noel. So back to you.
Oh my God.
And with that, I'm going to turn it back to you.
Dr. Pollard, you are queen of puns. So thank you so much for that NASHBID update. Let's go to our next segment. And with Shelley Polanco from Vibrant. Go ahead, Shelley.
Thank you, Megan. Hi, everyone. I'm stepping in for Stephanie from NAMI. She had a couple of updates for everyone. So as of last week, New Jersey became the 21st state, including DC, to receive an enhanced Medicaid mobile crisis match. So this map here, it is updated and highlighted with New Jersey being the last one to match being offered for the state as a result of the American Rescue Plan. As a reminder, the opportunity the match opportunity is available until March 2027. So we can go to the next slide as well. All right, so not many bill updates here. As of this year, there's only been 10 states that have enacted the 98 fee. But just wanted to highlight that all state legislators, including the 4 states that only meet every other year, will be meeting for 2025. So majority of the states will officially convene starting the 2nd or 3rd week of January and would wrap around the end of June. So just wanted to kind of highlight that next year is going to be pretty busy, but also wanted to kind of flag if you have the opportunity or are seeing something happening in your state, please reach out to myself or even Stephanie. We are kind of looking at states doing 90-day continuum of funding, also kind of an increase of just 90-day marketing, including student ID bills. Stephanie also wanted me to highlight really quickly the 90-day related legislation. So she wanted, if there's anything that you're anticipating for next year, I'll put in the survey in the chat as well. She wanted just for everyone to reach out to NAMI by the end of this year, so a couple of weeks, just to see if there's anything happening in your state, or if you're already hearing things happening in your state. Please feel free to fill out the survey, so that way we can kind of keep an eye on what's happening. So no more updates there. I'll turn it back to you, Megan.
Thank you so much, Shelley. Really appreciate your work and your update. And now let's go to Stephanie Hepburn. Stephanie, just really look forward to what this great crisis talk article is that you've done. Please tell us all about it.
Thank you. So I'm going to welcome Julie Goldstein Grummett, who's the Vice President and Director of Zero Suicide at the Education Development Center. Julie, in our interview, we chatted about a new Zero Suicide film that gives parents guidance and real life perspectives on how to parent after a child has a suicidal crisis. What I really enjoyed was the practical aspect. Parenting is a difficult endeavor, and I'm sure parents have so many questions after their child has a suicidal crisis. So it was an amazing film. So tell us a little bit about it. I know you came on previously and gave a little bit of snippet about it, a little summary, but it would be great to kind of dive into a couple of the points in the film that can shed light on what these questions are and how parents give guidance, as well as experts, and many of them are parents, sharing their perspective on what to do.
Yeah, thanks, Stephanie. Everybody should get interviewed by Stephanie. It's like chatting with a college friend that you haven't like caught up with in a while. So super fun. I'm so appreciative of being back on the Crisis Jam and to share this video and this film for parents that I really am proud of, because I know that this is missing. And so many parents have told us that this piece of information, this accessible information is just not out there in this way. So it really has been an honor to create this video. And the gist of it is really meant to be, as a parent who's going through this crisis with their own child, their child has talked about suicide, thought about suicide, made a suicide attempt. You have so many questions that emerge. First of all, you have so many feelings that emerge. And, to get those feelings validated of it's okay to feel scared, angry, terrified, frustrated, nervous, not know what to do, that needs to be validated for parents. And all of that, to take all of that in sometimes sort of on day one at the hospital or with a provider, sometimes we need to dose it. And so having it available via this video, I think was really important. Talking about evidence-based practices so that they can bring that straight to a provider and say, hey, I've heard about a safety plan. How do I do that? Tell me more, or DBT or CAMS. And then also those questions just that parents continually kind of have to grapple with, like, do I sleep in my kid's bedroom? They want to go to a party with their friends Saturday night and I want things to be normal, but they're not normal. But, or even when a kid says something like, if you don't let me go, I'll kill myself. And then you find yourself back in that turmoil. So we really interviewed a lot of parents and experts, and I feel like got a great sampling of these experiences that hopefully can be deeply impactful for parents. And while I have the stage, I just want to say, I really hope our goal with this is to make it widely accessible. So for crisis lines to be able to distribute it, first responders, schools, state education agencies, local education agencies, YMCAs, libraries, your state hospital associations, your FQHCs, it's a free film, and we want parents to be talking about it so that they know that they have access to it should they ever find themselves in this situation.
Well, thank you so much for hopping on with me, Megan. I don't know if we have a little more time. If not, I'll pass it back to you.
We do. Go ahead and take
do?
another
Okay, great.
minute if you'd like. Yeah.
So one parent was talking about just HIPAA. And I know for parents, this is incredibly difficult to navigate. Your child turns 18, what's deemed consent? And it really stood out to me because she said, even talking to the psychiatrist or the psychologist and saying, hey, ask my child. And that in itself, if the child affirms and says, yes, I'd like to have you talk to my parent, that is deemed verbal consent. So even just the nitty gritty, sometimes what really stood out to me also with the film is that sometimes you get films that are very lived lens perspective, very supportive. And then you get some that have some, practical guidance. This is the first time that I've really seen a film for parents that mixes both. And so just, for example, HIPAA, if you could talk a little bit about some of the other prongs that are brought up in the film that I think, listeners here and participants would be interested in knowing about.
Yeah, I think we try to talk some about myths that might come up. If I ask my child, will I put the idea in their head? We try to talk a little bit about communication with children or adolescents. It's really kind of meant in that 10 to 24 range even, so up to transitional age youth, which is why we brought HIPAA in. And that idea that some people you can't necessarily ask your kid every day, are you thinking about suicide, but you may have a strategy or a system in place, right? Is today a red day, a yellow day, a green day? What works? And finding your voice in that conversation with your kid, I think is really critical, and thinking about it in new ways. And so we really just tried to open a lens to say, this may not have been part of your engagement strategy with your kid before, but trying to demonstrate there are new ways to build that. I think the HIPAA conversation, even among our own team, we quite honestly filmed it several times to try to get it right. And it varies state by state. And
Yeah.
so it's hard to just make a movie for the entire country for every situation. But I think what we were really trying to do was pepper it with enough information to realize these are conversations that are safe to have, even if you have to dig a little bit to find out exactly what's works in your own state, but that thinking about it in advance so that you have information about your kid in advance is really critical.
And it also talks about safety planning, which I thought was so cool, having the parents say, this is what worked, and this is what helped our child. So thank you so much, Julie, for being here. I appreciate it.
Yeah, we really just hope it offers hope, right? So a lot of kids think about suicide, even a lot of kids make attempts. Most kids aren't going to die by these attempts, thankfully, but as a parent, it's terrifying even to hear your kids say, I think I want to end it all. I can't take it anymore. Just hearing that is horrible. So just trying to deflate some of that and give people hope and a roadmap. So thank you, Stephanie. Appreciate it.
Thank you both so much. This is just the idea of something so terrifying, but having support as well as hope, as well as practical strategies is just a wonderful thing. So thank you so much for your work on this. And let's go to Victor. Vic. For Strong Talk. And
thank you so
Vic,
much.
Put us into the new year.
I will do my best.
All right.
It was the week before Christmas, and all through the land, all the advocates tuned in for the weekly Crisis Jam. Megan was host, and she started the call with a message of hope as she welcomed us all. There was hot seat trivia. We were all in the seat. I say t-shirts for all, as we all did compete. There was Dr. Brett and SBIRT, as clear as percussion. There was Tracy and Stacy with the roundtable discussion. SAMHSA and NASBIRT updates, always a thrill. State updates, news from Capitol Hill. Great crisis talk with Stephanie and Julie, but to my dismay, no Galdis, no Betlock, no crisis calculator today. Thank each of you who join every week in this space. Through your efforts, the world is a much better place. You are beacons of hope, bringers of light for all who daily endeavor to fight. So on Vibrant and NAMI and EDC, on NASBIT and SAMHSA and AFSP, APA, MHA, and SPRC, on Trevor and Jed and TAC. Be hopeful, my jammers, as into 2025 we walk, for you don't walk alone. And that is Strong Talk.
I cannot believe you put what an awesome poem together. Number one, that fast, but maybe, oh my God, Victor.
Thank you. Merry Christmas to everyone.
I hope you see the comments in the chat about how amazing it is and the hand clapping.
Oh, thank you all.
Beautiful.
And thank you all for everything that you do. This is an amazing group, an amazing space, and I appreciate being a part of it.
Well, we're so happy you are. Thank you so much, Victor, for lifting us into the new year and into the holidays. We've got some great things coming. I will say that there is no Crisis Jam December 25th or January 1st because of holidays. And then the next one will be January 8th. That'll be episode 203. And we'll be discussing crisis line and imminent risk data with Ted Lutterman, Dr. Chris Drapeau, and Dr. Richard McKeon. So January 8th, we will see all of you. Everybody have a wonderful, fun, warm holiday, a great new year. Thank you so much for watching, and take care of yourselves.